Welcome to FP Executive. I'm here today with Giovanni Vatieri, consultant, health partner consultant from IBM. Welcome.
Thank you.
You have a really interesting background. You've been involved in the healthcare sector for years. You have been involved in mergers, trying to find ways to deliver better healthcare in Canada at a more efficient cost. Can you tell us just a little bit briefly about your background?
So I am a clinical chemist by training. That's how I started.
Okay.
And I've worked pretty much through the healthcare system over the last 24 years or so. Mm-hmm. So my focus was hospital mergers, and as part of that, when departments got integrated or hospitals got integrated, trying to find ways to create more efficiency either through process changes, technology changes, or organizational changes. So I got my practical experience in hospitals.
So you've seen real change occur in the past 20 odd years in your work experience, but now what you're trying to do is trying to lead change with businesses. You're continuing along a similar path. I'm interested if you could tell me a little bit about your experience with, for example, the Victorian Order of Nurses. I understand that you've done some work with them, that they had very much a paper-intensive process in terms of how they scheduled their nurses and the visits to people who need care, but they are now doing things a little bit differently. Can you tell me a bit about that?
Sure, and actually the Victorian Order of Nurses is a great example because they sort of epitomize a lot of the issues in healthcare in Canada in general. Mm-hmm. And while different organizations, healthcare organizations in the country are at different levels of maturity, I think the VON in particular was a good example of one that was a little more behind. Mm-hmm. So VON, simply, they're a health, home and community care organization. Mm-hmm. They're spread out across the country, 55 sites. And they've got about 5,000 nurses and 15,000 volunteers. And basically they go into people's homes and they provide home care. Mm-hmm. When we first started working with them, they were truly doing everything in the most manual way possible. Uh-huh. So, nurses would drive to someone's home and mm-hmm. they'd fill out pieces of paper, and then if they were lucky enough to have a fax machine in that person's home, they'd fax it from there. If not, they'd be going back out to their car and filling out more paper in their car, mm-hmm. And then when they got somewhere, either at the office or home, usually where they went to, they then had to fax or do whatever. So totally paper-based. They'd have to document their expenses that way, their travel that way, the clinical records that way. Everything was paper.
Wow.
At the beginning of every day, they'd have to phone in and get, where am I going today?
Okay.
Right. Now, this is pretty consistent across the home and community care marketplace. Mm-hmm. So VON is just one example of that. Mm-hmm. So what we did at the beginning when we started with them is to help them reassess, where they were at. Mm-hmm. Truly understand what their baseline looked like. Okay. So that you can't start a race if you don't know where the start line is. Sure. So that's what we did with them first. Mm-hmm. And that's where we learned a lot about what things they didn't do, that there were technologies already out there that they could take advantage of.
I see. So, for example, in terms of scheduling, was there changes in how, like, for example, rather than phoning in the morning, was there new technologies implemented that helped the nurses get to where they had to be quicker and more efficiently?
Well, what we're doing with them now is it's a broad program of things that we're doing with them because they needed, as an example, mm-hmm. needed a lot of things to change. Okay. From the way they managed their back office to the way they actually delivered care.
Interesting.
So our work with them is in all those domains. So for example, on the front end, mm-hmm. Now the plan is, and it's not fully implemented yet, they're still working, it's a journey, so it's going to take a few years to get there. But the intent at this point is, so as an example, we're rolling out devices, personal digital assistants in their hands, where it's going to tell them where their next patient is. Ah. It's going to tell them, give them an optimized route for how to go from their current patient mm-hmm. to the next patient. Mm-hmm. It's going to document the time it did to do that. It will document the associated expenses like travel and whatever, mm-hmm. so that now the expenses are also documented, and that's just to manage the process of getting to care.
Right.
So that's an operational efficiency thing that we're dealing with. Mm-hmm. The next step is then to use whatever learnings have come from now being a mobile care provider, mm-hmm. to then expand that to start clinical records. So they would go either to tablets or something where they would start actually documenting the care processes in a mobile way. So an iPad, for example, or an iTab would be an example of a kind of device that they might be able to use to actually do the clinical documentation.
Here, let's pause there and come back in part 2 and talk a little bit more about this in depth. Thank you.